Very excited. Okay, we can get started. Welcome everyone to Grand Rounds and to everyone who's watching from afar. It is my pleasure to introduce Dr. Jeff Ojemann, who is a professor in neurological surgery and a chair in pediatric, the Richard Ellenbogen Chair in Pediatric Neurosurgery. So Jeff did his undergraduate work in physics at Princeton, and then moved on to WashU for his medical degree and his residency in neurosurgical surgery. And then he did a fellowship, I guess in part in WashU and also in part here. So Jeff is going to talk to us about some of his research, and so he has research interests in cortical mapping and cognitive function and also the computer-brain interface, but I'm not sure exactly how much we'll be talking about that. And then, of course, clinical work has been epilepsy surgery and characterization. So with that, I will turn it over to you.
Great, thank you very much. Great to be here. This is great attendance. I did this once a few years ago. It's good. So I don't know who's out there listening, but last time I was pretty sure it was like Defense Department stuff. It turns out it was right. So just no disclosures. I want to talk today about, I'm going to switch to here, about the work that we've done in using electrocorticography to understand motor and sensory cortex a little bit better. Some of what we've done is just replicate what we already know about the homunculus and to show that this is an effective mapping tool. But then we've also been able to use this both to harness these signals for what Sumi was talking about, the brain-computer interface, or ultimately for neuroprosthetic applications. Because if you know when somebody wants to move or what they want to move, then there's obvious things that you can do with that. But we also have the opportunity to put electricity the other direction. And stimulating through these electrodes is something that's been around since really the birth of neurosurgery, modern neurosurgery, for over 100 years. But interestingly, that's not been well characterized, what really happens when you stimulate, and especially when you stimulate with a purpose other than simply mapping. In other words, give stimulation that the person has to interpret or use. And then finally, when you do things such as give feedback to the brain, it changes. And that's a fairly trivial and pedantic statement, but turns out to have some really interesting functional consequences. So where does the idea, the homunculus sort of invented kind of late medieval, early Renaissance, and it was, of course, the idea that the hominid existed either in the sperm or in the egg. It wasn't quite as male-centric as sometimes the model is agreed to be, but it did have the idea that the entity, the body, the person existed from the beginning. It's had many representations throughout Eastern and Western medicine, and the idea that you can represent the body in some mapping, one-to-one, usually not linear. I think that's an acupuncture ear. Some of these are actually really, some of the acupuncture models, I couldn't find one for this talk, but there's an acupuncture model of the scalp that really looks a lot like this. And so it's, I was curious. But this is what gets shown in textbooks, and most of this comes from work that Penfield had done at Montreal Neurologic Institute in the 50s and beyond, and has been validated by many over the years, more or less holds out. It's certainly the idea that the mouth and the hand have this huge representation compared to other parts of the body, and that it fits, of course, with classic clinical neurology as well. So how do we go about studying this? This is just the adult version that Rusty Novotny and his now very large team of neurologists take care of patients on the pediatric side. But this builds a lot on the interest in physiology, both clinically and research that John Miller's group has done. Mark Holmes, who's done an enormous amount of work with the high-density EEG, Shaheen, who's helped us a great deal and led the charge on some of the sleep and motor physiology, and then Jeff Sy, who has funding for visual recordings and EEGs and invasive monitoring. So this is all really built on the shoulders of an enormous amount of work. But what we found, and this started back when I was in St. Louis working with teams there and bioengineers, this really was kind of rediscovered by Nathan Crone at Hopkins in the late 90s, that if you open up your view of the EEG, the intracranial EEG, the corticography, beyond the 60 hertz noise band, so both for sampling reasons and noise, most of the descriptions were really below 50 hertz. And the EEG spectra and the corticography spectra falls off by, the power falls off by f to the fourth, the voltage by f squared. So if you double the frequency, you cut the power by 16-fold, which means you really don't have much signal when you get into higher frequencies, and you lose it very rapidly at the scalp. Interestingly, everything I'm going to show you, Hans Berger had described in some form in the 20s. It just was kind of hidden. Nevertheless, so we re-earthed that and showed, as many had, well known that when you move your hand, the low frequency power actually goes down. So at rest, you get a strong beta rhythm. And when you do something such as move your hand, you get a fairly broad decrease in that power spectrum of that band, the beta band and associated bands. And that's the green there. And that's over a relatively non-focal part of sensory motor cortex, even including premotor and post-central areas. But if you open the window in the frequency space and look, this is a log plot, so even though it may look like it's only about half or a third lower, it's really orders of magnitude less power, but really very dramatic contrast. And so if you can get your signal down in there, and your sampling rate down there, you see a very strong, even single trial increase in the power spectra. And it's very focal. So if you open and close your hand, you may only see 1 or 2 electrodes at this 1 centimeter resolution that will show this change. And then the other phenomenon is it's not restricted to a single frequency. So it's not really an oscillation in the classic sense of some very specific network, but rather looks more like an asynchronous, what we're calling a broadband idea. So that you're turning up the 1/f noise. And the idea is that when you get beyond the beta rhythms, the alpha rhythms, and so forth, and get beyond the line noise, then you see this very broad spectrum that increases. And so we can be agnostic as to what exact frequency we want and use the ones that are a little bit stronger and take a nice broad window so that we're not quite as dependent on noise. And this can be extended into speech areas as well. That's Broca's patient's brain on the lower left, and then you may have electrode over that area. And you can see if you just take the average of the power over this broader, we chose here 70 to 100 hertz, look at the speech tracing there, and you can see, if you look at the blue electrode over in the inferior frontal gyrus, and there's very strong signal noise. This is a single trial that precedes speech, and then in secondary auditory cortex, you get a response after speech, which isn't always there. There's much less activation in your own speech than others, but in this patient, we did see some electrodes that had a very strong response. So you can see the power of this single trial as a single trial tool. And here's another just example of this that we had from a few years ago where we took only 30 seconds of baseline, and then you'll see a color map on the brain for every 100 millisecond epoch that the power goes above 3 standard deviations from that very short baseline. So very, very rapid determination. And if it works. Okay. I had checked them, so. Anyway, what you'll see is in a single handshake, you would see the activity. So, okay, that one's not going to work. The rest do. And what we can see is that it respects what we would have thought in terms of the functional mapping of the brain and of motor cortex. So tongue movement is more inferior lateral. Hand movement gives you something that's more superior. The overlap is much less than you see for the beta decreases. And you can actually start to discriminate finer movement. So even with the resolution of these 1 centimeter resolution arrays, we can see a different activity reliably between the thumb and the index finger. And you can see it on a trial-to-trial basis. So I can classify with almost 100% accuracy whether you're moving your thumb or your index finger from the corticography signal. So our ability to map function in really more sophisticated ways is there. And now we can ask questions of, is this static? And the reasons why it may not be, and if you look at, this is just primate recordings. And the point of this is a fairly complicated slide, but the point is that if you have the animal or subject do something with the hand, with the wrist, especially if it's a somewhat complicated movement, there'll be a change in the distribution of responses. So in very short order, just over the course of a few trials of a fairly routine task, you will change what the responsiveness is of motor cortex, where certain things that you're using a lot will have a larger map. And we can see this after injury as well. So this is the general idea of people who've had injuries to their to the upper limb, either subcortical stroke or amputation. And you will see this reorganization where, depending on what modality you're using, it's usually transcranial magnetic stimulation or functional MRI, it's as if the face representation will expand into this vacuum that's left behind. And you can even see this in athletes or experts in whatever motor activity that you're studying, and changes when they're doing either imagery of their expertise or actually participating in it. And again, this is evoked as an explanation for the phantom limb phenomena, because you still have the mapping onto the body percept of these areas, even though they're absent. There's parts of the brain that have remapped the receptive fields or unmasked the receptive fields to this area. So if you lose a limb, a hand or an arm, that piece of the brain still can receive information from face or leg areas. So you're still getting the sense that your hand cortex is still getting activated or becomes activated by these other areas. And that's thought to be the mechanism behind phantom limbs. And we in fact had an example back when I was a resident with Dan Silbergeld, who's been here for several years. I'm sorry about the 1995, so the pictures are, it was rough back then with the pixelation. But the idea, this was a gentleman who had a traumatic amputation of his arm 20 years before the surgery and developed a temporal and frontal glioblastoma. And so as part of the resection on his dominant side, we did stimulation mapping. And there's a little gap there in black where we could not evoke any response, but that's really small compared to what was lost. In other words, where he got a jaw response, where he had a shoulder response, should have all been hand. So you had this brain that remapped to other areas that were adjacent. And then just as interestingly, up right next to that on the sensory side, you could stimulate an evoked phenomenon to a hand that he hadn't had in 20 years. This was somebody without phantom limb sensation, so it was some ability to perceive his body map or his body that had been preserved despite 20 years of no input. And so you can break down what the effects of our experience, or we can loosely call it plasticity, that gets to be sometimes a very specific term that I'm not exploring in terms of cellular mechanisms or changes in evoked potentials or long-term potentiation or any of that. But we do know that there are changes with practice, with exposure, that are behavior related. People get better at things. We know, and I'm going to show you examples of how the cortex changes with that. And then we also know things happen on the cellular level or subcellular level, and I'm not going to talk about those. So what's the model that we used? In some ways stumbled across it because one of the first things we did with these corticography signals, and for a variety of reasons we're motivated to do this very early, was to use them in a feedback task with the idea that, okay, maybe if this was a reliable signal and you have somebody who doesn't have any other mechanism of interacting, locked-in syndrome, something else like that, you could use this as a communication signal. So the question was, could you take this signal and volitionally modulate it for a purpose such as moving a cursor towards a target? So the design was here. You take a single electrode, you look at the bandpass power somewhere in that 70 to 150 hertz. Here we happen to pick 80 to 95. And then if the power goes up, the cursor goes up. If the power is closer to baseline, the cursor goes down. And we start, just imagine this just in the one-dimensional state. So it's either going up or down. Well, what happens, a couple things, and then we can also, to try and replicate what it would be like without proprioceptive feedback, we ask people to imagine it. And the first thing we notice is the signal's not as strong when you imagine it. It's about half as strong as when you actually do the movement. And that kind of 50% number matches other modalities, functional MRI primarily. But then when you do that feedback task I showed you, you're still not moving your hand. You will actually increase the power in that area to over what you had when you did the native movement. So your ability to volitionally change the activity in this piece of the brain is actually stronger than what you use with just a kind of mundane movement. And we saw this across a variety of behaviors, not just the hand, but also more proximal with the mouth, and even with speech, where feedback in the speech area was larger than the actual speech itself response. And then the other thing we found is that when you try to move the cursor to this one spot, is you get better at it. And you get better at it pretty quickly in the way we did this task. Some of that is just familiarity with the task, but even if people kind of got it from the beginning, they had a pretty steep learning curve, and this is over just a few minutes, so something we can observe at the bedside. Because remember, these are all patients with indwelling electrodes for treatment of their seizures. They're going to be in the hospital for a week or so, probably only have about 2-3 days where they're actually well enough to participate. but that's enough time to demonstrate this learning phenomena. And here's what it looks like. So when you start, this would be one of the first trials, and I've sped it up a little bit. The cursor, this is double speed. But the goal is to move the cursor to the target. The horizontal portion is fixed. And you can see that they have some, occasionally they'll get it. It's not very robust control. But then after a few days and a few sessions of practice, you can see a qualitatively different and very dramatic difference in their ability to do the task, which is really quite trivial. They just floor it to the direction they want, and their performance is close to 100%. So what's going on between these two states? Well, one thing that you can look at is how are they doing this? In other words, what's the dynamic in there, just looking at the control electrode itself. And what you find is not unsurprising. If you go, of course we did it after the fact, but if you go and look at motor learning literature, you would have predicted this, which is that you start out by increasing the power. So you just hit it harder and do it fairly indiscriminately. And so the red dots are the amount of power in that electrode when you were trying to drive the cursor up. And blue is when you're trying to keep the cursor or let it go down. It's a little bit less intuitive because it's sort of do nothing and it'll go down, which is obviously hard to do something. The blue dots and red dots are pretty commingled in that first epoch there, the run 1. The black line is the average distance between red and blue, and it's not very much, and it bounces around a little bit. And then they come back and do another run, and they've ramped up the difference between red and blue quite substantially. You see some of those reds are just off the chart. They've really kind of figured out how to ramp it up, but not very consistently. It bounces all over the place. And then what they do is they stop ramping it up. They stop doing this kind of indiscriminate blast, and instead become very consistent, where you see by run 4, there's really not a lot of wasted effort. The red is exactly where they want it to be, the blue kind of where they want it to be, and the variance from trial to trial is much, much less. And so we can show this in a variety of different ways. One is just what the power does, and you see there's kind of two places. One is where there's inflection, one is where they're really ramping it up, and the other is where they actually reverse direction, and the power on average is less. And then you can show this in another way where you just kind of look at the cumulative power over the trials. And the point here is that in the ideal state, the red and the blue curves are completely separate, with the red to the right and blue to the left, and that's what you see in run 6. And you can kind of get a sense as you march through the runs or look at the different distribution curves of how users are changing the distribution, how they're manipulating the control. So then we wanted to ask what happens to the rest of the brain. And the first thing, and this is a little complicated, but it's worth going through because it's a pretty interesting conclusion. And this is where we use the data of the control electrode to determine what is a learned and unlearned state. So all I'm showing here is that if you take a control electrode, we've had 6 patients, so we have the blue electrode, the electrode circled in blue on the upper right, and you look at the distribution of the power, and you just say, okay, are there 2 different distributions here? The idea being one would be kind of the early and the other the later state. And you force the distribution in that model, and you find some point that maximally separates the early and late state. So that's all just from that data. And then you go back and you look at the rest of the brain. And when you look at the rest of the brain, you see some pretty consistent changes when you're able to sample areas across patients. And usually it's premotor areas. Most of these patients we're covering sensory motor cortex because we're interested in finding frontal lobe epilepsy, and we're interested in the posterior boundary of that, which is usually motor cortex, especially on the right non-dominant side. So we have a fair overlap across subjects of premotor frontal cortex. And when you look at that area, this is one example of somebody who starts out. And this was control electrode from mouth motor cortex. So if you look at the panel in the upper left, there's a fair amount of red over mouth motor. That gets much redder as you go on. But what you see is the frontal lobe actually seems to get less red, and in some areas green, which is negative in that area. And if you ask what's the difference between the early and late state, you see there's a fair amount of green in the frontal lobe. So that means the power actually went down when you're doing the task compared to when you started. And now we can look at that on a single trial basis. And so you look and you say, okay, there's what you expect is that average response if it was an electrode that was moving the cursor. So it's going to go up when the cursor goes up, and flat or down when the cursor goes down. But now look, this is an area that's not the control electrode. This is in premotor cortex. And you see it's pretty tuned to up responses. The bar at time 0 is when the cursor gets going. You know which direction to go a little bit before that. But then there's this black line where the red goes away. But that black line wasn't determined from this electrode, it was determined from that data distribution that I showed you earlier. And so there really does seem to be this state change, and we look at this across people. Sometimes it goes the other direction, but we can show across people that there's a very specific network that is more active during this unlearned state than in this learned state. And I really should say early versus late, because it's a little too quick of a time frame to claim learning, and there's not enough data to say that the performance is statistically different, although across subjects there is. And this is what you see. You see that there are these areas in dorsal premotor cortex, just one gyrus in front, a whole bunch in further anterior frontal lobe, and then this temporal parietal or inferior parietal area that are much more active at the beginning of the exposure to the trial than at the end. And so that's interesting in and of itself, but what's also interesting is if you go and look at the literature for functional imaging of different tasks. And this was a meta-analysis of many different studies, and they saw this clustering over areas in right frontal lobe. This is neurologic coordinates, the right's on the right and left's on the left. Right frontal, right parietal cortex across a large number of verbal learning tasks, nonverbal tasks, and visuomotor tasks, where you ask the same question, what's different in the beginning and the end of exposure to this task? And these were exactly in the areas that we found with this task that nobody could have ever possibly done before, which is to drive a cursor directly from the brain signal. So, you know, on some level, I suppose you could ask, well, what else would they possibly use to do that? But it is certainly a remarkable example of the flexibility of our learning system. And so we then wanted to say, well, what else goes on? And one of the things that changes when you learn something is you see at least association with your sleep. And this is where expertise of Shaheen Hakimian and John Miller and others came in. And it's been known, at least Johnson is a postdoctoral, now a research scientist with the Center for Sensory Neural Engineering. That's a UW-based NSF center that I've been able to work with. And that's been an amazing source of engineering resources. But she had done some work with animals during her PhD, and this is a well-known human phenomenon, that these sleep spindles have a strong association in learning studies. And so people who have a lot of spindles after they see a new task and learn and do much better in retaining that skill if they've had more spindles. So cause and effect has not worked out in this, but you do see more spindles in the learners than in the non-learners. So we looked at this, and this was logistically kind of a nightmare because you had to have somebody who learned the task, slept, and the data was saved. So these are kind of 9, 12 gigabytes of data. But what she did is went through and looked at the sleep spindles in the night before the task was learned and the night after the task was learned. The night before exposure to the task and the night after. So in other words, the day before and the day after the task was learned, and then the sleep was in between, and looked at those sleep spindles. And so the question is, what happened to sleep spindles in successful learners? And they went up. And they went up in the area that was used for control. So you have pretty much the only new thing that these folks did during the time they were in the hospital, and that's the control electrode right there, number 33. And you see in that electrode and the ones next to it, and in no other electrodes, you saw an increase in sleep spindles after successful learning of the task. And you didn't see it in the non-learners. So something in the native learning system is being tapped into. Now let's take a slight detour and look back at our question of what we can do with this finger resolution. So the first thing now, going back to kind of what are the robotics or BCI, brain-computer interface implications, is to take this data. That's too bad. Okay, and map it onto the robotic hand. And one of the neat things is we can actually discriminate between different digit movements. So what that video was supposed to show is that when you move your thumb or move your finger or do a pinch, we get 3 distinct signals, and I can map that in real time onto a device. And the signals actually slightly precede the movements, and you can decode that fast enough that you can get a robotic response that matches very close to natural responses. But then we wanted to go further and say, okay, can we decode even more complex things? And so this happens to be a 3-year-old that Rusty and his team were taking care of, and we had an implantation of a somewhat higher resolution array because of the age and the location. and he was able to participate in 3 different grasp patterns. So he had 3 things of interest, and what you can see, and these are just a distribution of 6 different channels that were relevant to this. And there's some strong overlap, but there's also difference. And so you could take, by putting this into machine learning algorithms, you could actually tell which grip they were going to do based only on the corticography signal. And so we've applied this in older kids. And again, this was in as young as 2.5. We were able to see this difference between a sticker grasping a pen as grasping a stuffed animal. And so you can see the potential for these areas. And we can, if we now start to look at these movements with some resolution, we can understand the temporal dynamics, because that device, which has 22 sensors, will tell you when the different fingers are moving. And so we had a resident, neurosurgery resident from OHSU come up here 2 years ago, Hai Sun, and he looked at this data and came across an interesting observation. He said, well, you know, if you look at the cue and look at the different parts of the brain, most of the activity when you move is in M1. There's quite a bit in S1 as well. But interestingly, you can see that there's a very specific time pattern to this. And it's maybe not in the direction that you thought. So if you look at that time cursor, we're again seeing those high frequency changes. You're seeing it first in premotor cortex, but then S1 actually precedes M1 and not the other way around. And so you can see across individuals this interesting pattern. And we're going to come back to the importance of the sensory cortex a little bit later. But with these resolutions, with the combination of the corticography resolution, which is sub-millisecond, and then also these precise hand measurements, we can sort that out. And so it was really kind of the first example of an evidence of the planning of premotor cortex mapping first onto a sensory map. And people have described the efferent's copy of movement, where you have to basically have a plan that requires information about your state, your current state, before initiating the movement. And then we wanted to see, can we get even better? Can we go even further in the spatial resolution? So there are 1 or 2 groups that have been using what's called the brain gate, or the Utah array, which is a variation of what's on the lower left there, which is this very high resolution device that's been implanted intracortically in many primates. And there have been a handful of volunteers with tetraplegia that have participated in those studies. We have not gone down that path, rather continue to use our volunteers for people with indwelling electrodes. And then we've also begun looking at these higher resolution arrays that stay on the surface of the brain. So that's the upper left, the non-penetrating electrodes that are approximately 3 millimeters inter-electrode distance. We did some experiments in patients who were undergoing a weight craniotomy, where we just left them on for about 20 minutes, extended the surgery by that amount while they were awake, and tried to look at these same phenomena. And so what we see is, if you look at the scale of the children I showed you, that's the first cartoon with the red, so the second from the left. The clinical array, where really only 2 or 3 electrodes are involved, that's enough to discriminate the digits and pinch movement. But now if we capture most of those under what we're calling the microgrid, this is the 3 millimeter resolution, are we going to get any better? And what richness of movements can we decode? So here's a video that does work. And you can see when they're moving their thumb. So that skeleton there is a reconstruction of the individual's hand. And you just sort of go through, you'll see that there's a pretty large patch that's responsive to thumb, another large patch that's responsive to the index finger, and then the combination pinch movement is roughly the supposition of the 2. And that's the schematic on the left of what we did clinically. The first thing that we noticed, and this is Mark Holmes and Walter Friedman have shown this in the past, as with many others, 3 millimeters is about as close as you want to get with electrocorticography. So certainly down at the lower rhythms, the beta rhythms, there's a very, very strong inter-electrode coherence. So they're seeing almost the same signal. You still have about 50% coherence when you are out at the signals we're interested in, 75, 100 hertz. That drops off very quickly when you go to 2 electrode distance. So we expect that the 1 electrode distance, the 3 millimeter, will be right at the edge of the resolution that we'd expect from the surface. And in fact, we see very little evidence that we can discriminate on the electrode-to-electrode basis, but we certainly can see patches of cortex that correspond to fairly specific movements. So this is the way to interpret this is you have the 5 digits. We just map the curl movements from a variety of hand movements onto the brain. And you see in this particular example, there's not a ton thumb metacarpal movement, which would be really more of this adduction. You do see much more with the finger. Fingers 3 and 4 are a little harder to interpret because there's a lot of movement that goes along with that. But certainly the idea, especially in subject 2, that you can separate those out is clear. And then we can map that onto all the joint angles and see a variety of different patterns. So now can we do this same thing, instead of in joint space, go and do the space of different grips? So in this case, we had the subjects grab 6 different things that represented the spectra of different grasps and looked at it. And you can certainly apply different algorithms to sort this out. But you see there's, even at this resolution, there's a modest amount of overlap between these different grasps. So we thought that, okay, this is probably not a very good direction to go if you're trying to decode the intent of a movement. So if you imagine, where would you want to be with using corticography for a neuroprosthetic or robotic signal? You want to be able to tell the difference between, I'm going to grab that cup versus a piece of paper, and then actuate that. So we went back to some of the really neat work that's been done in hand motion literature. And what's known is with any movement, there's a lot of redundancy. And the hand in particular has a great deal of redundancy in the postures. If you just look at these 2 postures, and they're a little bit unnatural, so I still struggle saying exactly what the range of motion is. But if you take a wide variety of movements and do principal component analysis on it, 80% of the variance comes from just these 2 dimensions. And so one is an opening and closing of the hand. So it's a little bit trivial on that. Okay, you're grasping something, yes, your hand's going to open and close. But then the other is this more or less a pinching motion. You can see the 2 directions of it. And if you can map out a wide variety of grasps onto just these 2 dimensions. So the dimensionality of your hand is something like, depending on how you measure it, 22, 26, 28 degrees of freedom. But really there's only, and not only are there only 2 axes, but almost everything lives on that V shape there. So this is, 30 or 40 different things you can grasp, anything from a rope to an apple to an ice cube. And so anything kind of in that bottom point of the V is a grasp of something small, so a bottle or a coin. If you're doing more of a power grip, like a rope or a bucket handle, that's the upper right. And then the jar or CD or a large jar lid is the upper left. And so that means that we can actually do things and get control of grasp just by living along this, it's almost one-dimensional, certainly 2-dimensional axis. And so we looked at with the data that we have from these electronic gloves and mapped out, and what we found is that we got the first 3 synergies in particular are very, very reliable and match what's been pretty closely what's found in the literature. And so we asked the question, can we do that? Can we map these synergies onto the cortex? There's not a lot of anatomical specificity, so it turns out the brain is not particularly interested in one piece of motor cortex like synergy 1 and the other synergy 2. So that wasn't the case, but it does look like you can get independent channels and then go back and reconstruct the hand movements. And in fact, you can get an accuracy that's a lot better than what you can get with just reconstruction of joint angles itself. So we're trying to apply this to this model, which is what the center's dedicated to, and in this case, using corticography as an example to a controller, which could either be a robotic hand or maybe even reanimation of an arm that's otherwise been deafferented. So if we go back and look at these synergies, here's what we can do. So this is an individual had an electrode array over motor cortex. This is the 1 centimeter array. But we saw 2 channels that were close to being maybe more biased to one synergy than the other. Wasn't very strict, but we gave him the control of one synergy being the axes of that synergy space I showed you. So one synergy is going to make the virtual hand open and close, and the other axis is going to make it do more that kind of pseudo pinch movement. Again, I can't quite describe it, but it was in the slide showed what the 2 extremes of that movement are. And then the actual hand is a linear combination of those 2. So you're really giving the person a great deal of freedom to move the hand in those different domains. And then you have a target posture, so it's going to be a jar, a piece of paper, and a handle. And here we go. So this is the jar, and they're going, again, you can kind of see what they're doing with the bottom left in terms of which synergies, but they're able to get this hand into that jar space. That's the next one is the handle. There we go. And it's the handle case. And there the line indicates that if there was a case there, they would have made contact with it. And then finally, this one was a little harder for them to do. They're going to try to get it in the shape as if they were grasping a piece of paper, like pulling it out of a stack. And that one might have grabbed a jar if there was a jar there too. It's a little hard to say. Okay. So that's kind of where we stand with our ability to decode movements. But if this is ultimately going to be a true neuroprosthetic, then it's going to need to be bidirectional. And it's been known, that's Penfield at the top there, and then the tradition, including Art Ward, who founded the department in 1948, had worked with Penfield. And then my dad there, who did a lot with, to say the least, with stimulation mapping over the years. And in the departmental work in epilepsy world, much of the focus was on language. But in fact, the earlier work, which goes all the way back to Cushing, was in stimulation mapping. And so we know that we can evoke changes and do things with direct surface stimulation. And then we had just only a few yards from here work that Fetz had been doing for many years in looking at conditioning effects. And what he did was a really seminal experiment that came out in Nature almost 10 years ago now. And that's where he took an animal who he trained to do some fairly basic grasp tasks. And then he had an onboard chip that would record from one neuron and would stimulate another neuron, but only when you had activity in the first neuron. And so you have this simultaneous stimulation and activity. And what happened is this neuron that was being stimulated and the first neuron would start to synchronize. And they would start to have similar receptive fields. But what was interesting, it wasn't just the stimulated one that would change, it was the original one that changed. So even though there was no stimulation going into the recorded neuron, the fact that whenever it fired, all this other stuff would go on, as far as that neuron is concerned, it was in charge of it. And so it started to remap into the second area. So again, this wasn't a direct effect of the stimulation going down. It was heavy in plasticity because this whole network was being stimulated while this first neuron was firing. So the first neuron remapped and expanded its map onto the stimulated site. So that's what the upper right shows, is you had two neurons that had very different receptive fields or expressive fields in motor space, and the one that was recorded from started to move towards the green, kept some of its original direction, but now expanded over into the second neurons in space. And you had to do this pretty soon. There's a spike stimulus interval on the bottom. If you waited more than about 50 milliseconds between the neuronal activity and the spike, the effect vanished. So we said, can we do this in people? But we're not going to record from, yeah.
Sorry, could you
please.
Can you say that again, the timing of...
So you're recording from one neuron and stimulating a second one. And you have to see the spike before you can give the stimulus. And there's a delay to do that. That's a product of your computation and your machinery and all that. And if that delay gets beyond 50 milliseconds, then the two don't synchronize. Right? I mean, that, obviously in an extreme case that makes sense. If you're just firing whenever, there's no effect. So it has to be in that 20, 30 millisecond range. So we wanted to try this in people. We weren't recording from single units, we weren't stimulating single units, but we were recording from larger arrays, and we can stimulate, we do that all the time. There were no FDA-approved electrodes, stimulators out there for triggered stimulation, so something that basic, it's just never been developed. Except we found one, and it had a Y2K sticker on it, and was able to do this. So what we did was measured how responsive that piece of brain was to what its motor threshold was. Did these basic motor tasks, just have people move their fingers, and then stimulated one piece of cortex at very low levels, so way below threshold, single pulses, and then did that in response to the activity in another part of the brain. And that activity actually, in this case, we used the proxy of the EMG, which Eb had done as well successfully. And we tried to see if there was a response in the second electrode. So the idea is here that you record from one electrode, and then you would stimulate in the other, and then you would see if you could see these similar changes, which we thought initially would be a change in the evoked response from the recorded electrode. In other words, it would go from being a wrist flexion to maybe a wrist flexion plus rotation or something like that. So this was the setup. We had, for the interest of time, I'll just kind of move ahead to what we found, which was that we picked these sites of stimulation, and we did not see any changes. And we did not see any change in cortical excitability, and we did not see any coherent changes. So we really weren't able to develop any kind of co-interest between the two areas. So that didn't work. Okay. And what we did see was strange, and that was that so when you move your hand, as I showed you several times, you get a bunch of evoked change. I actually got muted, and the people had absolutely no sense that anything was going on. Their hand function felt completely normal, and was by testing throughout. And then here is what we found, is that you see this response. So these are electrodes that would change when you did the movement, and after a bunch of very small pulses, you couldn't see that anymore. And this we saw across all three people, that we had lost the detectability of this response, even though they functionally were fine. And there's an example here of when they would move their arm, move their hand. In the very upper right, you see a very robust change in the high-frequency activity, and that's absent there. And what we found actually is a change in the baseline. And so there was something, at first we thought it was just kind of a charge buildup or something weird like that, but it was very specific to these frequencies. And so what seemed to happen is we had mimicked, over the course of the stimulation, the active state. This all did wash out, and they were all did very well afterwards, and we did follow and assess them. But we had done something to the underlying high-frequency activity that really mimicked ongoing activity. So that was a clue that maybe something adaptive could be used with that. Then the other thing we looked at is there's been this ability that was well known in animals and also seen in people, that if you give a single pulse and then look elsewhere throughout the brain, you can see these evoked cortico-cortical evoked responses. So this is just giving a single pulse in one electrode pair and then looking everywhere else. And then again, going back to the Fetz lab, they were able to get a similar phenomenon to what I described, but this time instead of stimulating in response to a specific spike, they stimulated to the local field potential in response to the beta phase. So there are lots of different reasons why you think that might work, and association between the phase of beta and underlying activity. But instead of putting a wire in to record and find a neuron, you just put a pad on and said, okay, whenever beta phase is down here at the trough, I'll stimulate. And if you're not in the trough, you don't get any changes in the cortico-evoked potential. But if you are in the trough, then those two areas, the one you're recording from and the one you're stimulating at, will have a stronger connection based on that cortico-evoked potential. So you do the stimulation, and when you're done with all that training, you fire an evoked potential, measure it, and you see it's enhanced. So we were still brave and thought, okay, let's try that again. So this time, we're going to set this up, but we're not going to do it in response to the activity of the brain. We're not going to do it in response to EMG. We're going to do it in response to a beta phase. And this time it was different. This time we're not looking at evoked responses in the muscle, but we're looking at evoked potential. And what we saw is that the control electrode, which was on the right, we did not see any changes in the evoked potential. But on the left, at the site that was recorded, we saw changes that were dose dependent. So if you had just one training stimulation for beta, you got a little bit of response. With two, you got a bigger response. And three or more, you had a statistically significant response. And so just to blow up what that looked like, this is the negative peak of the evoked cortical response. The control is exactly the same across the trials. And the record, black is no stimulation. Each color is progressively more stimulations before the survey. So in other words, you're doing the training stimulations, and then at a stochastic time, you would stop the training and study the evoked potential. So we actually are able to, in people, enhance the connectivity between those two sites. Now, I don't know yet that that's going to be useful for things like stroke therapy, but the potential, the opportunity is that if one area isn't working and you can enhance natural connections to other areas, then that might be beneficial. So this is just an example of the different subjects we did this in. So as I've shown you, we can harness the motor-related potentials and record from them in a way that may be useful for neuroprosthetic work. We have some hint that that we can use this for rewiring or remapping. And then finally, we want to look, and I've shown you what some of the things we can expect with learning and practice. And then there's a couple other things that I want to touch on in the last few minutes. That one is what you can see, not just in the extramotor parts of the brain, but actually in the homunculus itself with experience and performance. And then second is just a very brief survey of what we're going to do with perception changes. So let me start with the perception changes. If you stimulate the brain, what does that feel like? That's a really sort of basic question that actually had never been answered in the 100 years of stimulation, with a few narratives, but not many. So one of the things we found is that it's a very unnatural feeling. It's a brushing feeling, and you can modulate it based either on amplitude, frequency, or the duration of the pulse train. So you can get down to pretty short pulse trains, even 100 microseconds, 100 milliseconds. That's it's 200 milliseconds of pulse, but with 100 microsecond individual pulse. So very short pulses over a relatively short period of time. And it has a frequency of dependency and an amplitude dependency, and they interact. So you can make use of this too to imagine that you could give feedback on a very short time scale. So then the other thing we want to do is say, well, what happens when you do a different type of motor task? And in this case, we had people do an isometric contraction. So they would hold this bulb at a specified force, and you'd get a bunch of activity in the brain. So anything that's kind of orange or yellow there is activation that's related to the degree of force that you apply. And then the reason we chose this is because it's very easy to measure what they did. It's not something like finger tapping where maybe they're going a little slower, maybe something else has changed the activity. We can, certainly from a behavioral point of view, quantitate it very well. And then we took one of those electrodes that was active in the force task and used that for the control. So there's no stimulation here, there's nothing else, it's just we repurposed that electrode, or used that electrode to do this feedback task. And they learned it pretty quickly, and then about 10 minutes later, we redid the force task. And so this is what the brain looked like in kind of a different format, the Gaussian blur here. So it's kind of the part of the brain that's active when you're squeezing this ball. And then we took that electrode right there and did the brain-computer interface task. And then we came back and did the force task again. So we have the homunculus, there's the hand area right there. And that's what we used for the BCI task there. And now we came back and did the force task, and the activity is less. And it's quite a bit less. And what we seem to have done is taken that piece of the hand and at least transiently turned it into a BCI area. So it really looks like, just as I showed you at the very beginning, that you can remap the homunculus based on your experience. It doesn't have to be a native motion that does that. And so you go from an area where this piece of brain seemed to be very interested when you were doing a motor task to where it really wasn't that interested. And this is right at the end of when it's been used for these other tasks. We still have to do some work to make sure that this isn't some sort of non-specific fatiguing effect, but based on the amount of the tasks that we've been able to do in the past over multiple sessions, that seems unlikely. So we see local effects. I showed you local effects in terms of how people modulate. It seems that modulation seems to do some sort of remapping to this piece of cortex. We've seen other parts of the brain that are very interested as you transition from a naive to an experienced state. And then finally, we have an idea of how to get at this question of the salience of the stimulation. And this is a really neat experiment that here I'm the subject of it there. So that's not my hand right there. My hand is behind the wooden box. And you can very quickly within about 10 seconds, get the illusion that hand is yours, because the experimenter there is stimulating my hand behind the box and the rubber hand at the exact same time. As long as those two stimuli are synchronous, you get a very strong sensation. They then even take a knife and go after the rubber hand and watch you flinch. We're not doing that to our patients, but they can even do it if there is no hand there. So you get this very strange illusion that you have a hand with an invisibility cloak on it or something right there. So we've just begun. The gentleman on the left is doing a 6-month rotation from Sweden and has started to work with us. Yeah, there's a knife right there. That stayed in Sweden. And then we'll also try to give cortical stimulation at the same time and see if we can evoke the rubber hand illusion doing that. And the prediction is that as opposed to feeling this very weird brushing sensation, as you give a sensation with a visual associate, it'll actually feel like their hand's being touched. So that's kind of the recent past, the current state, and where we want to go. To say the least, it is a gigantic group that is behind all this. I've shown you some of my clinical collaborators, the Fetz lab, which continues to grow. We've had really great opportunity for neurosurgery residents to work with bioengineering residents. Anybody is welcome, neurology residents. We have a very strong undergraduate education program that Lise Johnson now runs. Jared Olson, the junior faculty in rehab, that's joined us and is really leading the stimulation and stroke efforts. And then lots of funding agencies. And Raj Rao, who directs the Center for Sensory Neural Engineering, Bio and Computer Science, and has been a great collaborator as well. So a bit of a whirlwind. Thank you very much for your time. I don't see any virtual questions yet. Yeah.
So, and you may have discussed this, but are there stroke primates that you're, how will you study this?
Yeah, it's a great question. I just had that conversation a couple of days ago. I think a primate stroke model is tough, and you probably know better than I do what the best ones are out there, but it has to be one where you then can recover well enough to participate in these experiments. And that's where we have to go, because the other thing I'm learning a tremendous amount about are what are the requirements for these entry-level FDA-approved studies, and it's not clear. And I think that the preliminary data we have in people without a stroke, given the fact that there was a company now defunct, North Star Neuroscience, that had looked at cortical stimulation for stroke therapy. So the idea there was you stimulate during therapy sessions and try to get the same effect. It had a positive initial phase 2 trial, but the pivotal trial failed. And so the company then looked at some other things that eventually went bankrupt. So that's defunct. Whether this finding, plus that would be enough to go ahead in the stroke population for a subacute, seems awfully aggressive to me. But these are things without a lot of great, I'm a neurosurgeon, of course I should be aggressive, right? So yeah. But I think if we can do the primate model, we should. Still some challenges that we haven't found. So I think what you'd have to do is maybe some sort of selective, maybe get Jalal or one of his colleagues to put a catheter up in an MCA branch infarct, and then somehow make sure the animal recovers, subacute implant. You wouldn't want to do anything the first 48 hours or so with all the early changes, and then see if you could do this. But you're not going to be able to do 50 primates and show a statistically significant effect. So it really would only get you proof of. I think the next step, long story short, next step is talk to the FDA and see how much do we really need before this makes sense from that point of view. So I'm hoping Jared does that.
So would there be an equivalent of all of this with language function?
Yeah, I think that's that's probably even a better scenario there, especially if let's say you somehow resolve the question of would you rather have perilesional recovery or contralateral recovery, because you probably could drive with stimulation recovery in one direction or the other. And that's actually the one I thought of first, would be if you had a focus area infarct or damage, and you wanted to encourage connectivity to those areas that maybe weren't historically in that individual involved in expressive language, but we're nearby, then again, lots of suppositions here, but maybe there's an ability of those areas to encourage or unmask their underlying connectivity. So I think that's also very, very promising place. Unfortunately, right now, most of this human experiments are driven by a bunch of these brain initiative things, and some are driven through DARPA. So they're looking primarily, I shouldn't say unfortunately, they're very interesting, but they're looking at memory and neuropsychiatric things. So they certainly didn't start with the systems that were maybe a little easier to understand. They went straight for the goal. But, and we're a site on one run out of Penn on restoring memory. So it looks at temporal lobe stimulation. I didn't go into any of that. And I'm not, so far that's not, well, we'll see.
So actually promoting reconnectivity between neurons.
This is all at the same scale as what I've shown you, so we're stimulating probably 100,000 neurons, and lots of theories about, depending on what kind of current, are you stimulating dendrites or soma, and so that might influence what layer you're stimulating, but it's a very non-specific effect, and I think that's one of the big problems is nobody really knows what that range is. I mean, there's a little bit of data, especially from things like the neuropace, which is the anti-seizure stimulation, that some frequencies are going to be better than others for depending on what you're trying to do. You know, if I go too aggressively in a too high a current, I can evoke a seizure in anybody from any place. So these are all at lower frequencies, lower amplitudes. But nobody knows what the real range is, and it's very plausible that different patterns of stimulation would give you different things. These are just as with the sensory percept, it feels nothing like normal sensory cortex activity. And so presumably, if you're trying to get an area to be a better at memory, you're probably being really non-specific about it. So I think the idea that I'm going to decode what you see and then tell the brain that, okay, I'm seeing, peripheral vision, Rusty's over there and you're over there. We're not, that's just not on the table. I think if you want something where you're just trying to get an area to kind of perk up, and like what the non-specific things we saw with our stimulation, that's possible. And then I think you really are going to have to rely on the underlying plasticity we got a glimpse of before to make that. And some people are going to be able to do that in an adaptive way, and others aren't. And I don't think we know who's going to be which. I mean, I think one big curiosity I have is if you did have an infarct that included some of these premotor areas, could you learn, if you had, say, an EEG-based device, could you learn how to use that if you had included these learning areas in the damage?
Can you comment on the age dependent of this process
Yeah.
at both ends of the spectrum?
We don't have very old. I just laugh because very old, of course, depends on how old I am. But that's, so nobody's very old anymore.
Yeah, no, what you think about it, like in a 60 or 70-year-old.
Well, I mean, you could. The ultimate application in older is to not even get under the dura. So if you could do this epidurally, and if you only want 1 centimeter resolution, you can easily do that. And then Felix Darvas, who's a researcher in the lab, has been trying to find these things from the scalp, as you know. And actually, he and Jared have also been looking at subdermal or subgaleal electrodes. I think if you even could get through the bone, so a tattoo parlor where you have a little drill that stopped at the edge of the skull could get this electrode pretty close, and that would be much more tolerated, much better tolerated in either someone older or somebody who just had a stroke a few days ago. So that might be a much more realistic way to go. At the young end, I think as you know, we've done these, and other groups have done these feedback things. Young, about age 8. The high frequency change we've seen as low as 2.5 there, and that's probably evident from the scalp, given the thinner skull. And I don't think, so Rusty and I have mentored some people who are looking at Elizabeth Tremblay when she was here at even trying to see this in babies with passive movement. So that's still ongoing. But the beta and all that actually is very different. But the high frequency change seems to be just a marker of local activity, so it's preserved down as young as we've been measured. Okay, it's 5:30. Thank you. Good night.